Well, clinicians in large part follow the NCCN guidelines very carefully when the intent of therapy is curative. So if you look at adjuvant breast cancer, adjuvant colon cancer, where it's tried and true, or metastatic testicular cancer, where the intent is curative, I think you're going to find incredibly high concordance. When the intent is not curative, or even if you think it might be curative, like the immuno-oncology drugs, we're now using the word cure in melanoma. We didn't have that word before. So it's not crystal clear to me that it's that precise yet that NCCN guidelines per se are going to be followed to the level that they are followed in the adjuvant setting for established diseases. When you're going to give an immuno-oncology drug, you want to make certain first and foremost that the drug is approved for the indication you're going to give it, because they're very expensive and no one's going to want to be left with the drug not being reimbursed by a payer. The patient, the provider, the system. The second thing is as I was saying previously, is that you need time for the drug to work. And so in the indications where we do have approvals, metastatic melanoma, non-small cell lung cancer now, you have to know that the disease is not growing at such a pace that by giving these drugs, the delay in their response would allow the disease to progress to a point that it could hurt the patient. So you have to have some sense, this is different now. It's a dynamic where I do something today and it's going to be some period of time. And again, it's different. If with the anti-CTLA-4 drugs like ipilimumab, that time is longer than the anti-PD-1, and I'm sure it will be the same with the anti-PD-L ones, where the time is quicker. And we now understand why that is. But you have to have a little bit of time. So that's why these drugs are being used, and I think you'll see them used more up front. So in immuno-oncology, it's really interesting. We've had to throw away how we think about response. Your tumor may get bigger, and yet you're responding. Your tumor may light up brighter on a PET scan, as an example, and that's a good thing. Whereas if this were chemotherapy, that would be a bad thing. So time to response, response itself is much, much, much less important here than is overall survival. Even progression-free survival is tricky because you can get a flare in a tumor. I've seen this, I don't know how many times. I've helped develop these drugs, both the anti-CTLA-4 and the anti-PD-1 and now anti-PD-L1 drugs. And I see patients whose tumors grow as I'm giving them the drugs. And I tell them, don't worry, relax. And then the tumors regress. I also have patients that continue to have measurable disease, but it's not growing. So there's obviously an interplay between their immune system and the disease that's keeping the disease in check. So I think really the only true measure for immuno-oncology drugs, at least for now, that's going to matter is overall survival.